Good morning. I'm Eric Linzer, President and CEO of the New York Health Plan Association. On behalf of HPA and our member health plans, welcome to today's webinar, A History of HCRA and Its Impact on Health Insurance Premiums. Due to the concerns to the ongoing coronavirus threat, we appreciate everyone's flexibility in moving to a webinar. While we would have liked to have seen you all today, we obviously want to keep everybody safe and healthy. HPA hosts a number of policy forums and webinars each year in an effort to generate discussion and engage others in the healthcare industry on what we can do to promote safe, affordable, high-quality healthcare that's grounded in best practices. So thank you all our viewers for watching today's live stream, and we'll make this available on HPA's website later this week. We're pleased to have Bill Hammond with us today to kick off the discussion. Bill is Director of Health Policy for the Empire Center, where he tracks developments in New York's healthcare industry with a focus on how decisions made in Albany and Washington, D.C. affect the well-being of patients, providers, taxpayers, and the state's economy. Before joining the Empire Center in 2016, Bill spent almost 3 decades as a newspaper journalist, most recently as a columnist and editorial board member at the New York Daily News. Before joining the Daily News, he wrote for the New York Sun, the Daily Gazette of Schenectady, and the Post-Star of Glens Falls. He'll be providing an overview of HCRA for us today, what it is, how it started, the programs it finances, and the cost it adds to health insurance premiums for employers, consumers, and union benefit funds. Following Bill's remarks, we'll have a reactor panel will provide their perspectives on the impact of HCRA taxes and opportunities for reform. This will include Lev Ginsberg, Senior Director of Government Affairs with the Business Council of New York State, Robert Hinckley, Executive Vice President, Strategy and Communications and Chief Strategy Officer for Capital District Physicians Health Plan, and Sarah Rothstein, Director of the 32BJ Health Fund, who'll be joining us remotely. I'd also like to thank the HPA staff for their hard work putting together today's program, particularly in moving from our in-person forum to today's webinar. To make this somewhat interactive for our viewers, feel free to email me questions during the course of the program at elinzer@nyhpa.org. So feel free to send questions along. Now, to provide some context before Bill comes up, you may have seen results from Siena College's February poll that looked at the Medicaid shortfall and the prospect of increased health insurance taxes to close the gap. When asked about the best way for New York to close the $2.5 billion state budget gap caused by overspending in Medicaid, nearly 43% of respondents favored healthcare industry experts identifying cost efficiencies and ways to reduce Medicaid spending, while just 7% supported increasing taxes and fees on health insurance. Those individuals who supported increasing taxes on health insurance were then asked if they would still support increasing those taxes if it meant increasing what they paid for health insurance, or would they prefer a different approach in order to address the Medicaid shortfall. 53% of those individuals said that they would prefer a different approach, and that 48% of those individuals want healthcare industry experts to identify cost efficiencies and ways to reduce Medicaid spending. Finally, more than 80% of New Yorkers want the state to reform the Medicaid program to control overspending, rejecting increasing insurance taxes to address the current Medicaid shortfall. Ultimately, New Yorkers want industry experts to dig in to develop cost-saving solutions rather than imposing higher taxes that makes the cost of healthcare more expensive for consumers, employers, and union benefit funds. Given the fiscal challenges the Medicaid program currently faces, yesterday the Medicaid redesign team held its most recent meeting looking at potential approaches. Given these poll results, they ought to be rejecting new taxes. So whether it's increasing HCRA taxes or specific taxes on for-profit insurers or other taxes on the health insurance industry, when the MRT issues its final recommendations, rather than focusing on new taxes, the emphasis should be on measures to reform the Medicaid program and rein in costs. With that, I'd now like to ask Bill to come up, begin today's discussion. And again, if you have questions during the course of the panel, feel free to email me at elinzer@nyhpa.org, and we'd be happy to have those questions as part of today's discussion. So with that, Bill, please come up and join us.
Thank you, Eric. Good morning. My name is Bill Hammond. I'm the Director of Health Policy for the Empire Center. I'm going to give you kind of an overview of how the history of HCRA, how it works, what it costs, and where the money comes from, and how it's spent. As I was getting ready for today's presentation, there we go. As I was getting ready for today's presentation, I got a phone call out of the blue, somebody I'd never met before. He was a farmer from way up near the St. Lawrence River, in northern New York. And he'd gotten himself injured on his tractor, and he'd gone to the emergency room. He didn't have insurance, and he got a bill. I'm not sure how well this is going to translate on television, but he got a bill for about $2,200, and it included a line on it that said, New York State surcharge self-pay. And he said, why are they charging me for being a self-paying customer? And so I explained to him about a little thing called the Healthcare Reform Act. And that's what that is. That's what the Healthcare Reform Act kind of boils down to at the bottom. It's when you get sick and you go to the hospital and you get healthcare, the state taxes that healthcare. And right now they're taxing, in this case, they're taxing it at 9.6%, which is pretty heavy. So this gentleman had to pay an extra $184 on top of his $2,000 emergency room bill. The highlights of what I'm going to talk about today are that this is mostly, at this point, it mostly boils down to taxes on your healthcare. It started out as reform. The name reform in the bill was well placed. It really was reform when it started, but it's kind of devolved into just a source of revenue. That revenue is quadrupled in the last, since it first passed in 1996. It's now the third largest source of revenue for the state after income and sales taxes. By my very rough estimate, it costs about $440 per person for everybody who has insurance. There are competing estimates, but that's my number. There's no adjustment for ability to pay, so unlike income taxes, which are progressive and the wealthy pay at a higher rate, there's nothing like that in HCRA. And most of the money now flows into the Medicaid system, which traditionally was paid for with general tax revenues. And the last quarter of it is spent on these kind of specialized programs, a lot of which are either don't make sense at all or aren't run properly. So in terms of history, it replaced something called NIFRM, the New York Prospective Hospital Reimbursement Methodology. Nobody ever called it that, they called it NIFRM. And that was an elaborate law that regulated hospital fees. Everybody thought that by regulating hospital fees, they were controlling costs, and then a study came out that showed that no, actually, you're driving up costs with your regulations because it got so politicized, and the hospital industry was well represented in Albany. When that became public, that it was backfiring in that way, then Governor George Pataki proposed deregulating hospital fees. And as part of the deal, in order to get it done, they agreed that they would continue subsidizing hospitals for certain so-called public goods. And in particular, they would subsidize them for providing free care to the uninsured. And they would also subsidize the training of physicians. It's called graduate medical education. To finance those public goods, they levied these two new taxes. They called them surcharges. One was then an 8.18% tax on hospital services and some other, it was mostly hospitals. It doesn't apply to physicians or pharmaceuticals. And then there was also a per person fee called the Covered Lives Assessment. They started relatively small, but it was kind of like that first taste of an addictive drug, because once they opened that door, they were going to go back again and again and again. And so It underwent 8 major revisions over the next 12 years. Every single time it involved raising one or both of those taxes or adding a new tax. The patient services surcharge eventually was increased to 9.6%. The covered lives assessment was also increased. They brought in a bunch of revenue from other sources, including most significantly a big increase in taxes on cigarettes. Over the course of this time, the tax on cigarettes was increased to 8 times what it used to be. Also, since 1996, the way the money is spent has changed. They kept adding new programs, but then those programs would be subtracted a few years down the road. And over time, most of the money increasingly has just flowed into the Medicaid program. This just shows how revenue evolved over the years. Health insurance taxes remain the largest source of revenue, followed by cigarette taxes. And this shows what happened with spending. Medicaid was not really part of it when it first passed, and now it's the dominant program that this revenue supports. So why do I think it's unhealthy? Well, it adds significantly to healthcare premiums, 6 to 9%, according to industry estimates. And so that means your health coverage is less affordable. That means employers are going to find it harder to keep going in providing health coverage, and people who have to buy insurance on their own are going to have to dig that much deeper into their pockets, and some will choose not to buy insurance. And ultimately, people who don't have insurance are more likely to end up on Medicaid. So you're financing a government program, a safety net program, in a way that pushes more people into the safety net. It's unhealthy also because it doesn't have that adjustment for ability to pay. And this one is kind of crazy. I'm going to talk about it more in the next slide. The covered lives assessment isn't the same for every part of New York. It varies, and it varies by a lot. And then finally, I would say that a lot of the revenue isn't spent in a way, I mean, it's earmarked for healthcare programs, but that doesn't necessarily mean that it's being spent in a wise or efficient way. Okay, so this is the covered lives assessment. This is the rate per person for single coverage in different parts of the state. And I don't know how easily this is read on the screen, but the biggest bar there is New York City, $174 per person. And the smallest bar is Utica at $9 per person. That's a 1,800% difference. Originally they did it, the covered lives assessment was designed this way because it was financing teaching hospitals. And there were a lot more teaching hospitals in New York City than there were in Utica. And they didn't want to make the people in Utica subsidize the hospitals in Manhattan that they weren't going to use, but it doesn't subsidize teaching hospitals anymore. It's just a source of revenue, and they never got around to correcting this wild imbalance in how different people pay. Oops. This is the money, although it's levied on hospital surcharge on hospital services, it's actually paid by the health plans, by and large. And this shows how much it adds up to. It's real money for a lot of health plans. The #1 payer in 2016 was Empire Health Choice. Over $500 million they paid in this one tax. The next one, interestingly, the next highest payer is Medicaid. Medicaid itself pays the patient services surcharge, again, almost $500 million, and this was in 2016. It's probably higher now. And you can see a whole bunch of other health plans. And then I included at the bottom the 1199 benefit fund. 1199 is a big union for healthcare workers. Like a lot of unions, they have a benefit fund. And as the source of coverage for their members, they also pay a substantial amount, $72 million a year in 2016. So two examples of programs that I don't think are being properly managed that are financed by HCRA. One is it subsidizes med-mal insurance, medical malpractice insurance for doctors to the tune of about $130 million a year. Doctors in New York pay too much in med-mal insurance, so I sympathize with it on that level. But the reason for that is because the tort system is out of whack. And the answer to that is to fix the tort system, not for the taxpayers to pay more for their health insurance to subsidize a broken system. The other big program that's dysfunctional in HCRA is the indigent care pool. It should be compensating hospitals for providing free care to the uninsured, but the formula is so crazy that it underfinances the real safety net hospitals that are doing the bulk of the charity care. And meanwhile, it gives too much money to hospitals that are providing little or no charity care. I had some charts to illustrate that, but they're too complicated. And now I'll close with my analysis of why HCRA is addicting. First, because it's hidden from the public, and that makes it kind of convenient for the politicians who get elected. It's a way for them to get money without the people who are being taxed really being aware of it. You don't get a bill for this tax. It's built into your health premium that's paid by either you or your employer. And so you're not necessarily, I think the vast majority of New Yorkers aren't aware that they're paying this tax at all, except if they're uninsured and they go to the emergency room and then they get it on their bill. Also, it's perceived not as a tax on average consumers, it's perceived, at least in the legislature, it's perceived as a tax on insurance companies who are kind of, you know, they're happy to pick on the big bad insurance companies. Because it's part of Medicaid, for every dollar in this tax that they raise, they get a matching dollar from the federal government, and they feel like that's a good deal, and they're willing to make healthcare consumers pay for that deal. The other thing is that because it's earmarked for healthcare, the healthcare industry, mostly hospitals, nursing homes, and the unions that represent their workers, they're very powerful interests in Albany, and so they support having this tax continue. And then finally, and this is kind of the ultimate catch-22 of an addiction like this, as even if you agree, even if you see it the way I do, that this is a really unhealthy tax, if you want to reduce it, if you want to diminish this unhealthy effect, you are, quote, cutting healthcare funding. And that's a very difficult sell politically. I guess the final message I would offer as a takeaway is that in the current situation where you have a Medicaid deficit, it will be very hard to significantly reduce this tax, but it's also very important not to increase it because you're increasing the burden on taxpayers, you're creating more pressure for people to lose their insurance, and you're increasing the addiction, which I think we all should try to be kicking. You can get more information, more detail on my just published report on HCRA is available at empirecenter.org.
All right, great. Thanks, Bill. So at this time, I'd like to introduce the panelists for our discussion. And Bill, while you make excellent points about why it's addicting, I think you said it best when you talked about the charts that were essentially it's complicated. So it's a complicated issue, but at the end of the day, as you've heard from Bill, this ultimately these costs get passed on to employers, consumers, and employee benefit funds. And we're excited about the panel that we have with us today. So with us, I'd ask them to come join us. I'm going to start remotely with Sarah Rothstein, who's the director of the 32BJ Health Fund. As director of the fund, Sarah manages comprehensive health benefits for 32BJ's members and their dependents, and providing benefits to more than 200,000 people Sarah is responsible for developing innovative plan designs that improve healthcare quality while also reducing the overall cost of benefits. Prior to joining the fund in 2016, Sarah served as the Director of Policy and Planning at New York State of Health, where she oversaw critical aspects of the marketplace's data analysis, reporting, compliance, and training functions. So Sarah, welcome. Glad to have you were able to join us remotely. Also with us, starting to my left, is Robert Hinckley. Bob has more than 30 years of experience in health policy, government, and media relations. Prior to joining CDPHP, Bob served as Senior Deputy Secretary of Health and Human Services under Governor George Pataki, where he was responsible for the activities of 12 human service agencies and Medicaid, and will have a unique perspective on where we started with HCRA and how we got to where we are today. Earlier in his career, Bob worked for the New York State Department of Health, first as the Director of Public Affairs, then as the Deputy Commissioner for Operations, and he's a member and past chair of HPA's Board of Directors and previously served as the Vice Chair of the Commission on Healthcare Facilities in the 21st Century. Finally, to Bob's left is Lev Ginsberg, the Senior Director of Government Affairs with the Business Council of New York State. Lev's responsible for the Council's advocacy of healthcare and insurance, financial services, legal reform, and unemployment insurance issues. Lev sits on the New York State of Health Advisory Committee and served for 8 years on the New York Workers' Compensation Board's Medical Advisory Committee. For 7 years, he served as an attorney and then staff supervisor with the former New York Governor's Office of Regulatory Reform, and he began his career serving as a staff member for U.S. Senator Arlen Specter. So with that, thank you all for joining us today, and we're going to jump right into it, starting with, I'm going to ask the panelists, first starting with Bob, give me your reaction to the issues that Bill has outlined, concerns from the constituencies that you represent.
That's a loaded question. So I think, first of all, you have to look at HCRA and understand whether other states are doing this. And I think the answer is pretty much no, which tells you something right there. I think the second thing is that HCRA, at least the surcharge and the funding for certain programs, was initiated as kind of a transitory stage, but in Albany, very few taxes and spending programs are transitory. They all seem to take on a life of their own. And I think lastly, in terms of general impressions, what's mind-boggling is you have a program that's now spending $6 billion a year, and it gets renewed periodically, usually once every 2 or 3 years, without much debate. Bill mentioned in his report that in the first 12 years, there were a number of major revisions. At least during that time, there was a real hard look at HCRA. It ended up being increased spending, but at least people were looking at it and seeing what they could do with it to make it better. Right now, what we see is it just gets renewed as part of the budget with very little debate, very little analysis over whether the money's going to the right places. We hear, as Bill said, that some safety net hospitals feel they don't get their fair share of bad debt and charity care. They're probably right, but they get no voice in the matter. So I think that's a vitally important thing for us to look at, especially as we're going through this Medicaid crisis, is, are we spending the money the right way, and how much of this do we need? And then lastly, what I would say is, this is a tax on every individual, every employer. I won't step on Lev's comments because he'll speak up for the employer, but it's really hard for an insurer to send bills to their employers with this kind of tax embedded in it.
Lev, same question.
So, one of my main jobs and one of the main jobs of the Business Council is constantly looking out for the best interests of employers and what would promote, a good economy and a good job market in the state. And so we're often asked, why is New York so different? And I mean, there's a laundry list beyond HCRA. But HCRA is really, I think it's indicative of a lot of things that are sort of, that set New York apart and make us a very expensive state to do business in. It's a tax, it's a very large tax, it's a hidden tax, and it's one that burdens employers, I think, more than anyone else. Employers are, the leading payers of health insurance, and beyond that, those that are self-insured, take it out of the HPA context and the private insurance context, but those that are self-insured are also paying a HCRA tax in very large quantities, not unlike the farmer that Bill highlighted. And so they're quarterly sending in these giant checks also to the state to pay for HCRA taxes. It simply sets us behind on a number of measures. And it's interesting because, and granted, the conversation has changed in the context of the hole that we found ourselves in with Medicaid. But if you go to the last cycle when HCRA was renewed, and to Bob's point, we spoke a lot and we spoke to a lot of legislators about the HCRA tax. And in light of the ACA or Obamacare at the time, as we had more and more New Yorkers who were insured, we started to ask the question of why do we need to keep increasing the bad debt and charity care amount of money? Shouldn't that be going down as more people are covered in the state? Because there's no debate, because these things really never see the light of day, those questions rarely get answered. So employers are just left holding this $6 billion bag. And while the legislature looks at the HCRA tax as a tax on insurance, and consumers don't necessarily know, we all know that the ratepayer, the premium payer, I should say, picks up the bill ultimately for that HCRA tax. And in the context, it's no different in the context of employment. Some employers pay a larger share of the health insurance, and some have been forced to pay less and less because of the increasing costs associated with healthcare. So all of this rolls downhill to the consumer, to the employee. And it's really important that people understand that this is not something whose genesis is with their employer or with the insurer. It's ultimately with the state of New York.
Sarah?
Thanks, Eric. So as a self-insured health fund that provides high-quality benefits to low-wage workers, we have a number of concerns about the current structure of the HCRA tax. The first concern is that the HCRA tax is really a regressive tax in the sense that low-wage workers are taxed at the same rate as high-wage workers. And so the tax represents a disproportionate share of wages and benefits for low-wage workers. So that's our first concern. The second concern is that HCRA is just very expensive for us. We recently examined what we pay in HCRA taxes, and it's more than $60 million a year for our population of 200,000 covered lives, not all of which are in New York. That's just more than $60 million in the share of the population that is in New York. And so over the last 3 years, we've paid more than $185 million in HCRA taxes, which is 6% of our hospital medical costs. And that's an enormous sum of money. And I think that people tend to assume that insurance taxes are paid for by insurance CEOs or go to profit for shareholders. But we're a nonprofit organization. We don't put money towards profit. All of our dollars go towards benefits. And so that means that we need to raise an additional 6% of revenue just to pay the HCRA taxes. Our third concern is that this really isn't a value-based tax. We talk a lot about value-based payments in healthcare to try to drive healthcare towards value and goals we want to achieve. And we think that the tax is really backwards in some ways, in the sense that we pay more in HCRA taxes as healthcare costs rise, given the patient services surcharge as a percent of the hospital bill. Additionally, if you have two procedures at two different hospitals that have two different price tags for the same care, the state earns more HCRA revenue from the high-priced procedure than the low-priced procedure. And so it makes the expensive procedures even more costly for us and furthers the distortion in price variation in the market. and there's no mechanism to reduce the price variation through the HCRA tax, and we think that that's a real oversight. So those are our major concerns about the HCRA tax today.
Thanks, Sarah. That's a really good point on the last piece about, services get more expensive. The tax, particularly for organizations like yours and Lev for the self-insured employer, just means, higher exposure through taxes. So with that, so the state's currently facing a $2.5 billion shortfall in Medicaid. And among the directives given to the MRT recently was to close the Medicaid gap was by finding either industry efficiencies and or additional industry revenue. And as part of yesterday's MRT discussion, one of the items on the list of policy recommendations was the prospect of increased health insurance taxes. Now, while there wasn't anything specific to HCRA per se, there was still the discussion, or at least the recommendation, to increase health insurance taxes. I'm going to start with Bob and work our way down. How big a concern is the prospect of increased health insurance taxes for the constituencies that you serve? And what are some of the things that you hear when you guys, Bob, particularly when you and your folks go out to the marketplace, meet with employers, hear from consumers about the challenges they're facing with rising healthcare costs?
So let's talk about the taxes first. Our employers are facing a double whammy in effect. So as a commercial insurer, we're subsidizing the state's low reimbursement rates to hospitals and other providers for Medicaid. So to a hospital, all money's fungible. So if they're getting a lesser amount for Medicaid, they're going to take it out on commercial and want more money on commercial. So they're paying that kind of hidden tax there. Then they're paying the actual HCRA tax, which is, in essence, a double whammy. I think the other thing is, as we go forward into the market each year and bring our rates to employers and potential customers, when we get a 6 or 7% rate increase approved by the state, we actually are fairly happy about that, because in most cases, we're being pushed to 10 and 11% by the cost of care, but 6 and 7% is still way too high. So, we're constantly being asked, when are we going to see a flat rate? When is enough enough? And as we work to lower the cost of care, we're striving to get there, but increasing taxes just completely jeopardizes all our efforts to do that. So unless we get a handle on all of that, we're going to continue to look at 6 and 7 and 8% rate increases for the employers that Lev represents.
Lev?
So, Bob said that's a double whammy. I think it's actually a triple whammy, because the funding, or a significant portion of the funding for that Medicaid dollar, also comes from property taxes. Employers pay more property taxes than anyone. Businesses tend to pay more property taxes than individuals. So those people that are, that are employers in the state of New York are really paying for this 3 times. If we were to increase health insurance taxes in some capacity, it'll be 4 times. There's only so many times that you can strike at that dollar. The world has changed a lot, I think, in the last 2 weeks. In light of the coronavirus and all of the things that are going on, and employers either having people work remotely, or places shutting down, or schools ceasing. So there's definitely been some form of slowdown economically, and I think that we're yet to see how that's going to impact employers in the state. We also don't know, and the governor has asked the comptroller to look into what does all of this have on an effect of revenue coming into the state. Clearly, the stock market has taken a pretty significant hit, and that will likely have some downward spiraling on what the state's going to take in revenue. So the whole picture is sort of less money in the till. less economic growth, et cetera. Any more pressure that you put on health insurance costs, or, you know, the cost of purchasing health insurance or taxing self-insured employers is pressure that you're gonna put on the labor dollar. And the bottom line is an employer only has so many, you know, so many dollars that they can spend towards labor. If X amount, if it's going up, as Bob just indicated, 6 or 7% on the health side of it, that means that's money that you don't have to pay employees. So do you mechanize? Do you pay less? Do you just hire less people? All of those things have sort of that effect, and it really does in many respects start at the healthcare dollar, because it is the number one cost of doing business concern for our membership. You know, year after year, we're told this, and year after year, our members come to us and they say, what can you do about it? And, you know, it should be noted, and I think that this is a misconception both in the state and I think nationally, about, you know, profit in health insurance. We have no greater partner as employers in trying to reduce the cost of health insurance than the health insurance companies. Well, than an HPA for that matter. And you know, we work hand in glove with you guys all of the time to try to reduce these rates. And it really should be known out there that the push for the increases in this cost are not coming from this side of the table. And I'm not sure that the general public really realizes sort of who's on their side here.
Sarah, what, you know, concerns about the prospect of higher taxes through either HCRA or additional taxes on health insurance?
Sure, we have a few concerns. The first is that New York, particularly New York City, has some of the most expensive prices for healthcare across the country, and additional HCRA taxes will only exacerbate that issue and doesn't create any momentum for healthcare providers to figure out efficiencies or ways to reduce their prices. And that's always concern number one for us. Concern number two is that we don't have a mechanism to absorb additional tax increases into our budget. The way our fund works is that union members have collectively negotiated with more than 5,000 contributing employers for the employers to contribute the equivalent of premium to the health fund, which is jointly managed by labor and by management. We set contributions 4 years out, and so we know today what the money is that we're going to have for benefits 4 years from now. We haven't anticipated increases to HCRA taxes over the next 4 years, and should there be an increase in the tax that we don't have room for in our budget, we either have to start cutting benefits, which is not good for low-wage workers. No one should be in the position of having to choose between medical care and rent or food. Or we have to go back to our contributing employers and said, the state is forcing us to look for more money. We need to find it from you. And that potentially creates a challenging dynamic between the union and management that we really want to avoid. We are trying to take responsibility for figuring out how we can use our resources to lower the cost of healthcare. But if the state increases HCRA taxes, that really changes the chessboard for us.
Bill, as you know, in one of your last slides, you talked about the challenges with addiction to HCRA and you know, the ability or inability to lower the reliance on that. But what does it mean, you know, with the potential for further increases in either HCRA taxes or other health insurance taxes?
Well, one thing that I think needs to be pointed out is you mentioned that there's a $2.5 billion shortfall in the Medicaid budget. And that's a huge cause for concern. In Albany, there's a lot of debate. There's a Medicaid redesign team. The reason for that shortfall is not that there's not enough revenue, it's that the spending has gone too fast. The revenue, the state's revenue has actually been growing quite healthily. It's coming in faster than expected. That may not last given what's going on with the economy, but as of now, up until this point, we've actually been getting more revenue than the budget expected. So why would we have a shortfall on Medicaid? Because they've lost control over expenses. Overall enrollment has been flat for a number of years. Medicaid inflation is at an all-time low, or medical inflation is at an all-time low. It's because of mismanagement really by the state. Sometimes it's circumstances that caught them off guard. Other times it's decisions that they made that have blown up in their face. And they've been postponing and postponing action to control those costs. And if your response, when you finally get to the point where you're debating, how do we find 2.5 billion in savings? And if your response is, let's fill that gap by increasing taxes and providing more money, it's again, you're delaying the inevitable. Yet at some point, they have to find a way to control the increase in Medicaid costs. If you balance the budget with more revenue, you're just allowing those costs to continue to increase, and they're gonna have to come back in a couple of years and do another tax increase.
So we are getting some emails in from you, our viewers, one of which is just to extend the kudos to Bill for his presentation. And as a reminder to folks, if you have questions, we want to make this webinar interactive. Forward them to me at elinzer@nyhpa.org. Bill, picking up on your point about the spending growth, HCRA taxes, as you pointed out, have obviously grown significantly since its inception in 1996. I think for all of our panelists, and I'll start with Bill, are there approaches that the state should be considering as a way to reduce its reliance on HCRA? Maybe, not to the point, that you had made earlier, Bill, that it's difficult to, as you cut HCRA, you're potentially cutting healthcare, but are there ways that, either looking at programs or other things the state ought to be considering in reducing that reliance on HCRA taxes to fund particular programs?
Well, healthcare generally, not just Medicaid, but healthcare generally, the costs tend to grow year after year. They tend to grow faster than inflation. And so simply slowing that growth produces savings on your balance sheet. And that was the Cuomo administration's approach when they first came into office. They put a cap on the growth of Medicaid. They enlisted the industry to help them to live within that cap. They instituted a bunch of reforms, including enrolling a lot of Medicaid members in managed care plans. And for a number of years, it actually did work to slow the growth of Medicaid. Medicaid's growth in the first 4 or 5 years of Governor Cuomo's term was unusually slow. That resulted in billions of dollars in savings, and that helped the state return to a more balanced fiscal picture. Since about 2016, they have not been as successful in keeping the growth rate, and that's what led to the problem now.
Lev?
Keeping on the Medicaid side, Bill actually has put out a pretty comprehensive list of ideas where we could curb some of the spending on the Medicaid side, which would, of course, create some relief on the HCRA tax needs. I think that not to steal your thunder, Bill, on these, but I think that the most glaring difference, or the most glaring piece is the long-term care issue. The growth in Medicaid has been attributed in a large part to long-term care, and a significant portion of that is the at-home care. There's a number of components there. The easiest to talk about in a forum like this is the look-back period. If you go into a nursing home on Medicaid, there's a 5-year look-back. Well, I'll just finish this quip and then Bill can hop in. There's a 5-year look back, and there's lots of estate planning attorneys who make a living helping people make sure that 5 years from now, if they need that kind of care, they'll have that. But for the in-home care, the look back is 30 days. So it really doesn't take much to get yourself able to shed yourself of assets enough to be able to use that. So what we've done is we've taken a program that was designed to help people of limited means. And we've now made it a program that's accessible to people like me. Many years from now, I hope. And with a little bit of crafty estate planning, you can be eligible in a matter of a couple of months. So these are the kinds of things. To me, they seem like low-hanging fruit. They're easy to understand. It's a lot of money, but for one reason or another, the conversation is not just focused on things like that, it's focused on, the increasing of healthcare taxes.
Bill, did you have something you want to
I'm
jump
sorry, I interrupted before. I think a big picture strategy for controlling Medicaid costs is to make private insurance more affordable. We're at the point now where 1 in 3 New Yorkers is enrolled in Medicaid. That's an extraordinarily high number. That's the second highest share of the population of any state. And we're not a poor state. So, and part of the reason for that is that we have a very generous Medicaid program, but also part of the reason for it is that we had a lot of people who didn't have insurance, and so they needed to find a way onto Medicaid or some other state-supported program. If you had affordable private insurance, you'd have more employers would be offering insurance, you'd have more people buying their own insurance through the New York State of Health. And one obvious strategy for making insurance more affordable, a button the state could push that would make it like 6 to 9% more affordable overnight would be eliminating these taxes. Now, I understand that's a heavy lift. It's a lot of money to move around in your budget. But if that should be the strategy, if you want to control Medicaid costs, you want to limit the enrollment, you want to move more people onto where they and their employer are supporting their own healthcare costs.
There's also the novel concept of liberty, and allowing health plans to have a little bit more leeway in plan design, which would go a long way to that as well. I mean, right now, it's so hyper-regulated. There's no creativity when it comes to how to design plans for people that need services sort of in this lane, rather than making the lane wide enough to have every New Yorker. And I think that would go a long way to Bill's point of sort of limiting that pressure as well. It's a balloon, right? You squeeze it, the air comes out one place or another. We need more balloons.
More air.
So Sarah, approaches that the state ought to be considering to reduce the reliance on HCRA?
I think the other panelists really cover it. I'll just second Bill's comment that we need a strategy to make private insurance both through the marketplace and for self-insured funds more affordable.
Yeah. So Bob, on that point, are there thoughts that you guys at CDPHP or you yourself may have on ways to address that issue?
Yeah, first of all, I would echo Lev's point on long-term care. We have to get ahead of it. I mean, the sheer demographics of our society tell us that long-term care is going to become more and more necessary, more and more expensive. So we got to figure out ways to get ahead of that. And the look-back period is just, in my mind, a no-brainer. I think two others. I won't go as far as Bill and say just get rid of HCRA, because having served in government, I know how difficult that is. Certainly, we've got to better use HCRA. When we created HCRA, there was about a 13% uninsured rate. So, bad debt and charity care was a real important issue for the hospitals. Today, we're at 4%, but yet bad debt and charity care hasn't gotten lower. And it's inequitably distributed, so that, we have certain hospitals that don't really need it getting a ton of the bad debt and charity care. Lastly, what I would say is we have a hospital-centric system here in New York State. As Eric said in his prologue to this discussion, that they're a very powerful industry here in Albany. So the hospitals are controlling a lot of the spending. We probably have too many hospitals. That's a whole different panel, I would think. But care is moving out of the hospitals. It's moving into the community. It's moving into the homes. But yet we keep funneling money to the hospitals. And just recently I saw some of the hospitals were reporting 7, 8, 9% profit margins. It's unheard of. In the health insurance industry, we had a great year at CDPHP, 1% profit margin. And that's to go to our reserves to support our members, should we have a coronavirus crisis and have huge expenses. So That has to be looked at, and I think there's a lot of opportunities there. But once again, it takes that willpower to say, okay, HCRA's up for renewal. Let's kind of tear it down and rebuild it.
Bill, that's a great point about making private coverage more affordable. So whether it's addressing the taxes issues, or to Bob's point about provider prices, particularly as we deal with consolidation, and then the one piece that we haven't really touched on, but did have a forum on earlier this year around prescription drug costs. There's a number of levers that the state could be pulling, that if they're going to continue to rely on HCRA, then there needs to be some other relief valves for the marketplace. We are getting questions in from you, our viewers. Bill, I've got one specifically for you, asking if you can talk about the circumstances that move graduate GME, the GME spend out of the HCRA funds, and provide a little bit of perspective there. And then second, well, I'll get to the second question in a moment, but just maybe some perspective around GME and moving out of HCRA.
GME was always kind of a controversial part of this. If you look at what it is, it's subsidizing the education of doctors. Doctors, I mean, their education's really expensive. They often go into a lot of debt, but when they're done, they make, by and large, they make very good incomes. They're actually some of the best paid people in any state. And so it always was kind of odd that we would be using Medicaid, which is a safety net program for the poor, to subsidize the training of doctors. Ultimately, it was during the financial crisis of 2008 and 9 when Governor David Patterson, was just, the state was way over its head with deficits, and he prevailed on the legislature to take the money that had been spent on GME and put it into Medicaid, basically. So that I think there's still some de facto subsidies for teaching hospitals that are built into HCRA and into Medicaid and various other places, but that explicit GME pool has been empty since the Patterson administration.
So, Bill, on that point, the other question that we got: are there lessons that the state could learn, or policymakers could learn, about how we dealt with the GME piece for some of the other items you've identified as spending within HCRA, particularly, say, for example, Med-Mal?
I mean, Med-Mal, that's a tough one. I actually asked a legislator, who agreed with me that was not a good idea, that you were subsidizing a broken system. And I asked that legislator, well, why do you do it then? And the answer was, well, we're buying political peace. And I think you have to stop doing stuff like that. Another point that I make a lot in this context is it's the medical proverb, do no harm, first do no harm. Year after year, the legislature considers pieces of legislation that add to healthcare costs. A lot of them take the form of a coverage mandate. And so some crisis will come along. This year's coronavirus, and you will see a dozen bills put in that will say insurance have to do this for coronavirus, they have to cover this, they have to eliminate copays for that. Those bills add up over time. It hasn't been studied in quite a while, but they probably add a significant percentage to the premium we're paying for healthcare. If you just stop adding to the costs for health insurance, that would be a great first step.
So I would add to that, we're in an even numbered year, so that means we're going to get more mandates. It's an election year. And each one of those mandates, you'll hear the fiscal note to the bill will be estimated, 0.2% increase to premiums. Oh, that's nothing. Well, but there's 10 of that. That's 2%. Last year we had IVF, which, anyone can argue that that's, an important benefit to people, but that added a significant amount to people's premiums. So everyone is paying for that increase. And at some point, we've got to say, our health insurance program is comprehensive, which it is. It provides the benefits people need. We can't keep adding to the cost. Otherwise, we're gonna start a cycle of going back to that 13% uninsured down the road.
There was and the name is now escaping me, but there was a panel put into law to look into the unfunded mandates on private insurance. And it was going back like 10 years. They never sat, they were never impaneled, and then it was done away with maybe 2 years ago, I think, in either sunsetted or it was just ultimately done away with. But we have never sat down and taken like a hard and holistic look at all of at this point, there's over 40 mandates on private insurance for these kinds of coverages. And also, different programs like the medical malpractice subsidy, if you will. We never take a real look at the healthcare system. People like to talk about this as a system. But if we ever sat down and did a real look at the mandates and a real look at the cost of malpractice, or malpractice cases, and maybe considered reform in those areas, maybe some of these savings would only be marginal, but a marginal decrease is significantly better than continuous marginal increases. But we're just we're not serious. The legislature has not been serious about taking control of these kinds of things and doing a long, hard look. I think that would be an excellent first start.
Sarah, I wanted to pick up on an issue that you raised earlier about the challenge around employee wages and benefits. Yesterday, Cranes had reported a new innovative program that you guys have launched around maternity care, and while that'll be a separate conversation with some of our folks next month, I did want to get a sense from you as to, as HCRA taxes or taxes on insurance potentially increase, how does that challenge not just the piece around employee wages, but your ability to come up with invest in new and innovative approaches that address the cost of care, improve the value of the services that your employees receive, and making sure that coverage remains affordable for your folks?
Thanks. I appreciate that question. And one of the things I want to reiterate is that the health fund is jointly managed by labor and management, and it's a unique and very strong and collaborative partnership. And both sides are invested in ensuring that our 200,000 plan participants have high quality benefits that are low cost for our plan participants, so they're not having to make choices between medical care and other needs in their life. And HCRA taxes raise the cost of our benefits, no doubt, and I've shared some of the data on that. I think in terms of when it comes to innovation and our ability to use plan design features to figure out how we lower our costs, I think the spotlight on HCRA will require us to rethink about where we put some of our clinical programs. So for example, we're exploring a Center of Excellence program for certain procedures. And one of the questions that we're going to have to think about is whether we want to have a Center of Excellence opportunity in New York City, where the majority of our plan participants live and work, or whether we want to move that Center of Excellence out of state to New Jersey or Connecticut, where the negotiated rates are cheaper, but we also don't have to pay almost 10% on the patient services surcharge and could save 10% off the bat just by moving care across the river. We wouldn't do that for routine care, but on something like major planned surgeries, that might become worth it for us if HCRA taxes become cost prohibitive here in New York.
That's an really interesting point, Sarah. And sort of picking up on the regionality issue, Bill outlined and Sarah's talked about this a bit, sort of the different, the regional differences that get charged, for various taxes based on place of service, region of the state. I mean, given the regional differences that the impact that HCRA taxes have, I mean, does this affect employers in where they think about where they're going to set up shop? Not just whether they're going to come to New York, but where in New York they might think about either adding setting up shop or increasing their employee base.
So I'm not sure that it may be one piece of a larger puzzle. I mean, these site acquisition firms go out when a business is looking for a site, and they consider a host of issues. They're considering the cost of healthcare, the access to healthcare for that matter. They're considering workers' compensation costs and other labor costs, energy. Unfortunately, the state of New York, especially in places upstate, a little less on the HCRA side, these are tough numbers compared to other states. So the healthcare dollar number is a really tough number for them as well. So I would say, yes, it's baked into it because it's baked into the cost. But whether it plays one region, the HCRA taxes alone play one region against the other in that respect, I'm not certain.
Bob, you talked a bit about health plans having a good year with a 1% margin. Now, when plans go to submit their rates to the Department of Financial Services for review, taxes are obviously built in there. Give us a sense of the challenges that you guys face in building the rates that, on the one hand, allows for, that have to be actuarially sound, but, on the other hand, tries to remain competitive in the marketplace, given these added costs that put, pressure on health plan premiums.
Yeah, I think what it does, what the taxes do, because, CDPHP and all our competitors pay the same taxes, it sets the bar a lot higher. So we're working from a deficit right off the bat. Even though medical inflation has been somewhat tamed over the past few years, you're still talking about a rate of increase in the state for medical care from one year to the other of anywhere from 3 to 5%. So you're starting out with a rate increase at that level in the best years, but then you have the added pressure of taxes, mandates, all that don't allow you to invest in the type of programs that might bring that trend down from 3 to 5% to something lower. And then you have that extra concern, like in a year like this year, where there is some talk about raising taxes and assessments on the insurers to pay for Medicaid shortfalls, where it could push those rates up even higher. So in a year where medical inflation might be 2%, statewide or whatever, you could have 8, 9, 10% rate increases just because of all the other factors.
So in the interest of time, we are starting to run up against the hour. I'm going to take one more question, or provide one more question. This is one that I've tried to typically use in some of our other forums. I'm going to crown each of you healthcare czar for a day, and whether it's addressing HCRA taxes or some other mechanism to make healthcare more affordable, or to address the Medicaid shortfall, I'm going to leave it up to each of you to give me one idea that policymakers ought to be thinking about, considering, and potentially implementing as a way to either address the reliance on taxes, close the Medicaid gap, or make healthcare more affordable in the private market. I'm going to start with Bill, knowing that you've got at least 11 or so ideas that you had outlined about a week ago, and I'm sure there's plenty more that you may have.
I mean, in a way, I'm going to repeat myself, but I think like what's missing in the legislative discussion is any focus on affordability. There's no caucus for let's bring down premiums. To the contrary, there's a line of legislators who their idea of controlling cost is to eliminate copays for a particular procedure, which it may save an individual their out-of-pocket amount, but it adds to the premium that everybody's paying, the employer and all the employees. If you, Lev mentioned, I forget what the name was, it was the Healthcare Cost and Quality Containment Commission or something. That was a really good idea. Massachusetts has it. You could probably talk about that. It analyzes existing laws and proposed laws and how they're going to impact the premium. It doesn't say do this, don't do that. It just puts the numbers out there. So when the members of the legislature vote, they know, okay, when I vote to pass this mandate, I'm adding X% to the premiums of all my constituents. that step alone, if you had that transparency and if you just had the awareness in the legislature, I think that would help.
Yeah, and Bill, to that point, Massachusetts has the requirement to not just look at the cost impact of proposed new mandates, but also the efficacy to determine whether the science is right, it's best practice. And in addition to that, to your earlier point, that same agency every 4 years is charged with looking at the cost of existing mandated benefits, if for no other reason to provide policymakers, the public, and others with an understanding of what these things cost. So
That's actually, there is this federal panel that looks at it doesn't even look at cost, it just looks at whether a particular procedure is good for your health, and they rate it, they give it a letter grade. A lot of the mandates that I see, I go and I look up whether that panel recommends the procedure that they're talking about, and often they don't, they recommend against it. And yet the state legislature is passing a law requiring insurers to pay for it.
So we might have our next policy form based on Bill's idea. So Lev, ideas for either containing costs, addressing the shortfall, or dealing with increased taxes.
So 2 ideas. One, and it's back to the envelope math, but if we spend more per person in Medicaid than any other state. If we spent approximately the same as California per person, we would save $24 billion a year. There are playbooks that the MRT could be looking at. There's 49 of them, 49 other states that could show us how to save money in Medicaid. It would, and look at one of them, pick 3, combine them. It's an easy enough lift. There's 49 other states doing this in a less expensive way. And then ultimately, I think a lot of it boils down to if I had the power, I would allow for better plan design. And for a host of reasons, not just cost. There are those of us that want a more enhanced plan than the one that we have, and we're willing to pay more. There are those of us that certainly don't need it, that would be happy to pay less. And I think those 2 things, we would be in a completely different world. There's a lot of hindrances, and I think those are 2 of them.
And, Lev, on your point about other states, we took a look at, just a couple of states to determine who's doing it, what's the next state that is dealing with Medicaid increases. If you just sort of brought New York's costs around managed long-term care down to around 7%, which is what, Florida's dealing with, the state would have saved probably about $500 million, or could save about $500 million on a going forward basis. And that's something that the MRT ought to be considering. And, on your point about, again, sort of, new benefit designs, sort of meeting consumers where they are, where employers are. Again, I think we might have, we're getting a bunch of new policy form ideas out of this morning's conversation. So, Bob, your ideas?
Make Lev and Bill the co-stars. I agree with everything they said. I think we've developed a healthcare system that's very maternalistic / paternalistic. We have a set of benefits, and it's kind of a cookie cutter approach, and people are different. Different ages need different benefits. I think we have to be more flexible in our benefits. On a broader health funding policy basis, I do believe we need to tear down HCRA and rebuild it. I don't think we need to throw it out because the old system was bad. The NIFERM system, if people talk about 3 men in a room in Albany, the NIFERM system was worse. Was filled with political log rolling. The state set all the rates, and it fostered a hospital system that was all based on cost plus. So there was no effort to ever wring out costs out of the system. So I think we need to better use HCRA, and I think we'd be in a lot better shape. And then on the mandate commission concept, I think we need to stop rolling from one crisis to another, creating an MRT to address this crisis and an MRT to address that crisis. We need a group that sits down and looks at the system on a regular basis, because the healthcare system changes, our needs change, and we need to look back to say, did that change we made 3 years ago do anything? Did it work? Did it save money? Did it provide better care? And if not, let's change it. So, that takes a huge amount of political willpower, but we're sitting on a system that needs a lot of help, so.
I mean, a great idea for sort of an ongoing commission, and then, perhaps maybe sort of a HCRA commission to look at, how we're spending it, does it make sense, and does it meet the goals of expanding coverage, improving quality, and lowering costs.
Absolutely.
Sarah?
I think I'll pick up on the comment that Bill made about the value of care that's being provided. One of the things we're doing with our claims data is assessing the quantity of care that's being provided that has no clinical value. Everything from EKGs to patients who don't have health problems to high-tech radiology for uncomplicated low back pain. I think since we're all inventing this new commission, one of the things I would task them to do is to figure out what the plan is for New York to eliminate the provision of that care that has no clinical value. It would reduce the dollars that would have to be spent by all payers to pay for care, and could probably then also reduce the HCRA taxes that are needed to be raised to pay for that care that has no clinical value.
That's a great idea, Sarah. Considering that the amount of time and effort put into value-based payments, perhaps, there needs to be some better rules of the road, guardrails around all of that. So with that, thank you all for being part of today's webinar. This has been an interesting, informative, and a really great conversation. Sarah, thanks for joining us remotely, and to all of our panelists, thanks for being part of today's program. And to you, our viewers, thank you for taking the time to watch online today. There will be a link to today's program up on the HPA website later this week. And with that, thank you all for participating, thank you for watching, and have a great rest of your week.